Hello, and welcome to the Complex Care Journal Club podcast. My name is Emily Goodwin. I'm a pediatrician in complex care at the Beacon program at Children's Mercy, Kansas City, and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I am delighted to have Dr. Renee Turchi from St. Christopher's Hospital for Children joining me today. She is the senior author of an article, A Virtual Home Preparedness Intervention Centered on Children and Youth with Special Healthcare Needs, published online in Academic Pediatrics in June 2024. Dr. Turchi, thank you so much for being here.
Thanks so much for having me here today.
We'd like to have you share a bit about your study, starting with the gap you identified and your research aims.
Sure. So I had a colleague, Dr. Esther Chernak, who had included me in some disaster preparedness work with children with special healthcare needs, like right before COVID. And as we did some secondary data analyses in that work, it became really clear that while all children are at risk during emergencies and disasters, and we certainly, even prior to COVID, have experienced a lot of things related to as far back as Katrina, thinking about storms, there's earthquakes, there's fires. But thinking about children with medical complexity, just snowstorms and rainstorms based on their needs, if it's related to technology, if it's related to life-saving medications, if it's related to their visual or hearing challenges or physical mobility challenges, are at a particularly high risk. We wanted to do a deeper dive and actually connect with families to really understand their challenges and really know at a more personal level, hearing from them directly and doing in-home assessments. So we were very fortunate to be funded by the CDC to do this work, and we focused specifically on Pennsylvania, and we were very intentional at sampling across the Commonwealth, looking at families that represented different sociodemographics with respect to where they lived, recognizing urban and more rural areas. Pennsylvania is a largely rural Commonwealth, might have different access challenges. We wanted to get families that represented diversity and include families that spoke languages other than English and had support for that. And also really wanted to have families that represented, in addition to racial and social demographics, also diversity with respect to diagnoses. So looking at children that had physical mobility challenges, technology dependence, vision and hearing, communication, and then behavioral challenges or cognitive challenges that might make it difficult for them. So we're very intentional at purposeful sampling, and we're ultimately able to include 179 families in our study. Our goals were to understand the needs and knowledge and gaps for children and youth with special healthcare needs when facing an emergency or a disaster, and understand their emergency planning and perceive susceptibility, and really trying to understand, do I actually think my child is at risk or that we're at risk? We also wanted to understand how the social determinants of health influenced or informed some of our families' needs and challenges. That was a big part of what we assessed. And we also spent some time in the study looking at how we could, based on some of those needs, do an intervention. So we had an intervention for our study where we gave them that everyone got a core packet, including an evacuation plan, shelter in place plan, local numbers and resources for their community, fire evacuation routes, and access to smoke alarms. And then depending on gaps, we tailored a packet that might meet their needs. Some of the needs involved needing medical equipment or refills or some psychosocial support. And then we had community partners to help fill those gaps. So we worked really closely with the Red Cross, our medical legal partnership, our Family Health Information Center. We also had a medical equipment provider on our team, as well as social workers, community health workers, mental health providers. And then we followed families up between 3 and 6 months after that initial assessment to see, in fact, if there was any difference made in the knowledge, the experience of the interview. And we also did a qualitative interview of we wanted to hear from the families in their own words, what were some additional needs and gaps. The last thing I'll say was that we really wanted to spend some time really working with the emergency medical services and the emergency response teams. And they were key partners in our work, as well as folks in Medicaid and Title V. We really wanted to work on bringing families and emergency response personnel as we learned things from families to help support that workforce so that we could foster partnerships between families of children with youth with special healthcare needs and emergency responders and some of the policy folks.
Thank you. Yes, I love that your team addressed not just emergency preparedness, but day-to-day needs. The social determinants of health really affect every aspect of someone's life. And so I thought that was so important. And the partnership with all the different stakeholders that informed your study, but also connected them to all the different resources in the community. I wonder if you want to tell us a little bit more about the various roles on the study team or how you came up with those items in the question and interview guide.
Yeah, so I think in terms of the study team itself, we had a lot of planning that went into this. Certainly, that included lots of wonderful experts from the CDC and colleagues around the city and national experts. So, having folks that had experience with respect to disasters and emergencies and thinking about what kind of things might we need to be asking and addressing. We had an advisory committee that included family members as well as policy folks from EMS. We had folks from the police force, Red Cross, Emergency Medical Services for Children. We also had folks from Medicaid and Title V, our Pennsylvania chapter of the AAP Medical Home Program. We had some additional local family groups. There's a group called UNE that's a family advocacy group that handle everyone, but they have all Spanish-speaking parent advocates. We had a medical legal partnership. And we found as we were doing some deeper diving into the social determinants that having some supports with some of our local food banks, we identified food insecurity, were really instrumental. And we also partnered with our local fire department in Philadelphia and statewide. So we had multiple domains on our tool. We were funded, and then we had a year of planning where we developed our tool and had to get the things through the IRB. And while all that happened, then COVID hit. Our original plan was to literally go into the homes of the families. And as we were developing the tool, we started thinking about who should be on that core team. And we had identified families from medical home practices, because one of the things that I think is a real pearl in the research for us, like doing this intervention, as we were designing the tool, we really felt like ethically, if we identified something, let's say we did identify things like, for example, a family might have needed a piece of medical equipment. We wanted to make sure that all the families we recruited were connected to a medical home. We really felt like it was important ethically that anything, and I believe this strongly in research, if you identify a need and you screen, you have to be able to provide that resource. And so we were very intentional as we were developing our tool to think through what questions we were asking, and we literally mapped out a process. Okay, if there's an affirmative response to food insecurity, what is the resource? And we literally did like asset mapping, and we just really felt like that was a big ethical part of the study, was that anything we asked, we had to be prepared to address. And we also wanted families to feel comfortable answering questions honestly and candidly. They were consented by their PCPs and enrolled in the study, but the folks that actually conducted the interviews, we felt like, given the nature of some of our questions, we had 2 social workers, we had a bilingual community health worker, we had a durable medical equipment provider who happened to be a respiratory therapist who was on the pre and the post calls. And we found that to be invaluable. Families, we got a lot of wonderful feedback from having him on. So especially with their cameras, like all families were pre-tested to be able to, all our families had smartphones, and they were very comfortable with the cameras showing the equipment. And what we found was particularly valuable was certainly making sure there were backups and thinking about emergency planning, but there was a lot of day-to-day things that were identified where he was giving families tips on setups, tips on oxygen regulators, tips on like how to, families sometimes had questions if maybe they felt like they needed some more orientation. We developed something called go bag lists for families that he went over. We developed them for children with asthma, children with feeding tubes, children with ostomies, tracheostomies, ventilators, children with oxygen and catheters. It includes everything you need to like grab and run. And we gave them like a checklist just to keep that tailored to that child's need. They got the go bag that was relevant for them. And it was just something, whether they had a home care nurse or they themselves, they could just make sure that all those items were in that bag and talk to them about checking for expiration dates. Another key partner for us that I think is worth mentioning is that, as I said, the Red Cross is a key partner. Every family got a shelter-in-place plan, evacuation plan. There was something called shaker bed alarms for children that might have sensory needs, or if they're deaf or hard of hearing. There's light-up smoke alarms, but there's also like these shaker bed alarms that, I'm not oversimplifying it, but it kind of is like this little egg-type device that goes in the mattress. They're quite expensive because you have to like link them to the fire alarm system. Every child got, Red Cross would come in and install the smoke alarms for them. But if they had any particular needs that would need like an adapted fire alarm, the Red Cross came in and they did one-on-one evacuation route plannings if families were interested. And they talked about meeting places. I think the fire safety was really instrumental. During the time that we were conducting our study and data gathering, just in Philadelphia alone, there were several fires that had taken the lives of some families, and in one case, a family with a child with disabilities. And so it just seemed very timely and relevant, and obviously tragic that there was some disasters, but just raised the awareness for a lot of our families. And a lot of our family partners, they were instrumental to be part of the study team. There were some great resources that we have. There's a tool, for example, called Show Me, which is like a suite of tools that enhances communications between any individual, child or adult that might have a communication challenge, and public health and emergency management personnel. When EMS comes in, they're trying to help their child, but if their child's nonverbal or maybe he's getting very agitated because it's an unfamiliar person touching them, how do we help integrate the teams? And that was also a key partner. In our family partners were instrumental in giving us feedback on their own experiences with EMS or having to evacuate, what that was like. And again, I think a lot of the tools that we tried to give to families were based on some of the areas of challenge and opportunity for them.
I love that. I'm going to have to look up those resources for some of my patients too, or maybe you can share them so we can post them for other listeners to check it out. You mentioned some opportunities and challenges, one of them being doing this intervention in the midst of the COVID-19 pandemic emergency. I wonder if you could elaborate if there's other opportunities or challenges that you identified while developing and conducting your study.
It was really like an interesting pivot for us because at one point, knowing that we couldn't go into the home, we were concerned because everything we had proposed was going into the house. That's something I'm really passionate about, is meeting families where they are and recognizing that while we do things in the office, and for those of us in complex care, there's so much that we try to accomplish. If you're in the home, then you're really thinking about, well, what am I going to do to evacuate, as opposed to something much more hypothetical or ethereal, like talking to a family about evacuation route when they're sitting in our office. So I think it was a great research experience for our team to pivot to Zoom. It took a little more in terms of preparing because the tool could take upwards of 1 to 2.5 hours, depending on how complex the child was. But what we ultimately found when we asked some of the families, it was very interesting. A lot of them told us that they weren't sure that they would have actually participated if it was in person, because just the intimidation of allowing a group of strangers into their home. And our family partners said, even if COVID hadn't hit, we probably would have needed to offer Zoom anyway. And as we completed our study, a lot of families really felt like the Zoom was perfect because it allowed them some privacy. We felt very passionate about including families that speak languages other than English. And we were able to have certified medical interpreters be a part of our team. And I think one of the things that we were very intentional is that by doing that, because there was translation, those interviews by definition took longer. So our team was very flexible, and we were upfront with families that maybe we might need to break up some of the interviews into 2 or 3 parts. We talked with the families a lot about how long they were able to be on Zoom. They obviously had other responsibilities. I think that it's so important to include families that speak languages other than English, and we got the resources translated into those languages, and we just factored that into our budget. A research area for us that we were really passionate about is that while we certainly felt really good about the resources that we were giving to families and that we hoped they learned something, we wanted to give $50 gift cards to families for each arm of the project. And while that still didn't cover, I'm sure, all of their time, we just felt really passionate that we learned so much from these families. Families are the expert in their child's care, and it is time for them. And we felt that it was very important that we remunerated them for that time. I think depending on who your funder is, sometimes you have to justify the amount you're giving. We worked with our family advisors. The last comment that I would make about some challenges is that I feel like there's a paucity of research for children with special health needs in general. I think that one of the things that we experienced is that to do research with our families that have children with medical complexity, their lives are so unpredictable. I think a lot of our families experience so many challenges, or maybe it was a nurse call out, or maybe someone got sick. And so I think I just want to encourage all of us to have the tenacity to hang in there and work with our families and recognize that it fosters our understanding of the empathy we need to have for our families and our children and youth with medical complexity and their day-to-day lives being sometimes so unpredictable. We reflected as a study team, there was a lot that was gleaned just about what some of our families, some of their day-to-day challenges are, and not giving up because sometimes this research may be harder to schedule, or just recognizing that's part of what our families deal with every day and how do we best support them. And so I just encourage us to continue to do research with this phenomenal population.
Those are great lessons learned for other researchers, but also clinicians. What do you think are some of the implications for clinical practice? Specifically, what do you recommend for members of the interprofessional care team?
That's a great question. Some overall, unfortunately, emergency and disasters are ubiquitous. I was out in California for an AAP meeting, and it was humbling for me. I'm learning from some of my colleagues that they do more with earthquakes. Just thinking about where our geographically, it's where I am in Philadelphia, there's lots of storms. Wherever we live, not everything is a tsunami per se or a massive storm, but there are so many things. If you think about even a snowstorm or a rainstorm that may preclude a family from getting a delivery of supplies, preclude a home care nurse from maybe being able to make their shift, and now a family's on 24/7. I'd love to do these individualized tailored assessments on all of our kids. One of the things we advocated for in Pennsylvania is emergency planning and disaster preparedness plans are in all of the home care orders for kids with home nursing. There's a lot of children that have home nurses, recognizing that sometimes can be sine qua non with maybe a need for skilled needs with technology dependence, but having those nurses have go bags, think about evacuation routes. I think the big thing for clinicians too is I don't think you necessarily have to do this in-depth home assessment that we did, but I think some implications from our research are thinking about some key partners. We used the emergency information form at Seattle Children's. There's many out there. That was the one that we chose to adopt for our study that we felt like fit our work best. There's tools like that. And a lot of those, especially now with EHRs, can be pre-populated. So giving families like we do with care plans, there's integrated care plans with things like an EIF form, connecting them with the local Red Cross so they could get their smoke alarms, they can get that evacuation plan, thinking about some of these resources so that you as the clinician, I think it'd be not necessarily feasible to expect that clinicians are going to go through an evacuation plan when most of us have never been in our patients' houses, but lead them in the direction of some of these shelter-in-place evacuation plans, connecting with getting the appropriate smoke alarms that often can be free and can be tailored for children and youth with medical complexity that might have communication challenges. And also, I think a lot of us are doing the social determinants of health. But as we think about that, thinking about some of our families and what some of those challenges may bring. Just to give a very concrete example, some of the families that we had done this process on in some inner city Philadelphia, when our Red Cross and our fire team went out to the home, many of the families had bars on their windows for safety concerns. So these are children who are not going to be able to be rescued through the window. So just thinking about some of those challenges that families may have that are informed by some social needs that they have that then might inform how they evacuate, and recognizing that connection between the social determinants. And also, in many cases, we have caregivers that they themselves have needs. Thinking about, as a clinician, I think the other area is technology, things like having a secondary charged ventilator. Thinking about there are programs to get generators for families so that if families feel like, hey, I'm not going to be able to go to your typical hotel, families obviously can always go to the hospital. But if you think about just having that plan, thinking about children working with technology, Another pro I would say that we've really took from this research is for those of us caring for children with medical complexity, recognizing that medical equipment providers are key partners. And I learned so much from this study, even having been in this space for many years. I feel like our DME provider provided so many ideas for our families. Some of our families came back to help us think about some of those cross-system partnerships. And I think another take-home message would be connecting. I mean, Family Voices has some great resources in this space. The local, wherever you are, connecting with your local family health information center and maybe some other local parent groups. I think hearing from families about what the needs are, knowing your local community, and hearing from some of our families in more rural areas that one of the challenges is some of the parents would say, I don't call 911, I put my child in the car because it's quicker for me to get them to the hospital than maybe waiting for EMS because they're in a more remote area. So having some of those conversations with families, what do they do if it's an emergency? If they're putting their child in the car and that's the only way they can do it, doing things like helping them think about, can someone come with you? Do you have that go bag? Taking that backup trach in the lower size? Thinking about some of those checklists, and happy to share some of the resources. I think recognizing the role of some of our community partners like the emergency responders. We've been doing a lot of connections with them. They're very eager to hear and learn more about children, how to approach a child with autism. As we see these children evolving their needs annually or every 6 months, and keeping some of the emergency planning and some of these key partners as part of that care plan, part of that emergency information form, and really knowing some of your local partners, because it doesn't necessarily have to be all on the practitioner. And if you have ways to make referrals to do that, it can be as easy as putting some of that in your after visit summary and just having some of those resources identified, I think would be things that would be really helpful for some of our practicing clinicians for children with medical complexity.
I love that. You might not have time to sit down and do an in-depth interview or checklist, but even having a list to refer to say, hey, it's time to update your care plan or make an emergency form. Have you ever thought about what you do if the power goes out? Or here's a list of things that maybe you could think about, or maybe we do a telehealth follow-up. It really gives a lot of different ways to think about this proactively for things that clinicians and families just might not have thought of. And I love that we don't have to be the one that always has the solution, but being knowledgeable about local community resources and how to partner. It's given me lots of ideas to think about in my own practice as well. I wonder if there's any messages for patients and families that you have specifically from your study.
I think working through some of our family advocacy groups are helpful. Start this conversation with your provider. Hey, I've learned a little bit about disasters. Can we talk? What do you think? Should we have a separate form? And I think having our families feel comfortable being the one to have the impetus for these conversations is important. And I think one of the things that we learned a lot from talking to families is that, as we know, our families have so many day-to-day challenges. And recognizing for families that emergency planning is definitely something, thinking about things like go bags and recognizing and thinking about the various places that a child or youth goes. So that as you were to develop, let's say, a go bag or emergency information form or an evacuation plan, not every child has a home care nurse that's accompanying them to school. So thinking about, are they at school? Are they at pre-K? Maybe it's a youth that's in a work program. So just thinking about all the places that a youth or a child might have. And with some of our families, a lot of times they put stuff in their phones, or they have, as part of their child's care plan, have copies of some of those evacuation plans as part of their child's portfolio. We included things in our EIF that would be things that would help, that might be very unique to a child or youth that one might not think of, that could calm them down. Thinking about a fire alarm going off, or how anxiety provoking that is for any child, but having a child with special healthcare needs, maybe it is that singing to Tommy, or making sure you get out of his bag that this is his lovey or something that calms him down. And I think having families understanding their goals and understanding, having their input and engaging families. They had a lot of feedback about the value of having a medical equipment provider when relevant, and really engaging with families about some of these key partners, because while providers certainly can make the referrals, families themselves can reach out to the local Red Cross, get the smoke alarms in. A lot of the folks now, even if families are renting, they have these 10-year wired smoke alarms, but there are removable smoke alarms. We did a lot of investigating on this because families were worried about putting things in the home that they'd get in trouble with their landlord. And families can reach out themselves and get some of the home assessments, put a request in for shaker alarms. So I'd say that we really felt that certainly there's pieces, and it's not at all to minimize the role of the PCP for things like getting equipment, but a lot of the community partners are available for families to think about and reach out to, and really also just recognize that they know their family best. They know what their goals are. One of the things that I think was something that came up from a small portion of our families, we have a form that we fill out in Pennsylvania. I'm sure other states have it. But several of our families talked about when they had children that might have different goals of care, and maybe on palliative care, or it might not be full resuscitation. It was another resource that we had that, again, can come from a family so that they feel comfortable calling 911, but there's like a form that they have so that if they had goals of care established with their care team, that they have these papers available so that their wishes and their goals for their family and their child can be valued and honored. And really thinking about families partnering with EMS, them being able to talk to teachers, home care nurses, folks that might be with their child when they're not, to help make any type of unanticipated emergency or movement as least anxiety provoking for that child and traumatic for the family as possible. So I think really giving families some of this information, they can also take some initiative and work in partnership with their medical home to accomplish some of these things could be a win.
It seems like it made a difference too. The mean preparedness score in your study improved significantly from baseline. So I think these things are really making a difference, and hopefully will give lots of families and clinicians ideas of ways to better prepare. You mentioned in the article some of the qualitative study findings are being examined. I wonder if you could talk a little bit about the important next steps from your work.
Yeah. When we started off on our study, we wanted to think about this as a pilot. We wanted to really focus on proof of concept and make sure that it was feasible. And as it turned out, because we had extended time, we actually got to, our goal originally was 100, we got to 179. And we were thrilled to show, as you mentioned, that like we really developed this index of the various domains. Amazing statisticians, Dr. Burhani and Dr. Kim on our team that helped us with a lot of this data and the analyses. And we were thrilled to show some improvement. We felt passionate about this work, but it was an added bonus to actually show that it was statistically significant. And in the article, we have a lot, as you can tell, in terms of the sociodemographics of our study and looking at the diagnostic categories. One of the things we have 179 qualitative interviews. We really wanted to hear from families because we felt our tool was long and there were some opportunities for an open-endedness, but we really wanted to hear in families' own words. Did we hit the mark? Would they do this again? Would they recommend it? What worked well? What didn't work well? A lot of families gave us feedback that they just felt like this was a lot of, wow, didn't know what they didn't know. And we saw a lot of shifts in that perceived awareness, perceived susceptibility, and just even like the self-efficacy of the families that they really could be part of this process. And it was really interesting for us in the qualitative study to hear from families about what is their biggest fear or they see as their child's need in an emergency and disaster. What do they perceive to be the biggest need? And sometimes I think as a clinician, we can self-impose what is the medical need. That was a really big thing. One of the other things that we found that was really humbling for us as teams, as I said earlier, we picked families that we thought were connected to a medical home, which were, because for the reasons I mentioned earlier, so that we could make referrals. Families still had a lot of identified gaps in areas where with social determinants or needing additional equipment, needing refills. And so that was something we've been reflecting a lot on the qualitative research, is saying, is this the tip of the iceberg? What about families who maybe aren't connected to a complex care practice? I think also one of the things that came out in some of our qualitative research was family support system. Certainly some of our data collection occurred during COVID, but we had several families that we referred for mental health services for themselves when they were receptive to it, just feeling isolated. And just, I think COVID also highlighted the need for a lot of backup caregivers. A lot of families were on 24/7. And I think that we found that we really wanted to have a conversation. We got a lot of great feedback from our families in terms of things that we could do a little bit better. Seemed like overwhelmingly families felt like it was useful, but families appreciated that we addressed the social determinants. We had a lot of referrals around that. And I think some of the other parts for them recognizing that we could make the connection to how this was all an integrated picture of the partnership.
I appreciate that. You don't know what you don't know, and you also don't know if you don't ask, right? From the clinician standpoint, and lots of valuable lessons from this study. I really look forward to hearing more when you publish about the qualitative findings. So thank you so much for your time, Dr. Turchi, and thank you to you and your team for advancing the field of complex care.
Thanks so much for having me, and thanks for this opportunity.
And thanks for listening to the Complex Care Journal Club podcast. We aim to highlight research that has the potential to be practice changing, that values patient and family engagement, is relevant across disciplines and diagnoses, and uses high quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in this podcast using the form provided on the Open Pediatrics YouTube channel. Thank you for joining us.